think that your patient has bacteria in their blood, you can take some blood cultures. Now, even though you'll only grow something 5 to 15% of the time, blood cultures can be life-saving, because if you do grow something, then you can get antibiotic sensitivities and therefore target your treatment and save your patient, which is a good trick if you can pull it off. Now, when is the best time to take blood cultures? The received wisdom is that whenever a patient spikes a temperature, you take blood cultures. The idea being that if there's bacteria in the blood, this is causing an inflammatory response, the release of cytokines, which causes pyrexia. This is common sense, isn't it? If there's bacteria in the blood, that will cause fever, and then that's the time you should take blood cultures if you want to grow anything. Well, it's all wrong. It's rubbish. And we've known for at least 70 years that bacteremia precedes the fever by about 2 hours. We think this is probably because by the time that the fever has appeared, the immune system has mounted enough of a response to clear away the bacteria, enough that there's very little chance of growing anything. Now, even though we know this, it turns out this isn't actually that clinically relevant. The largest study to date of 1,172 positive blood cultures showed that even though there was a small effect size in the 2 hours preceding the time of maximum temperature, overall there was no statistically significant difference in the timings. Okay? So if you take away one message from this video, it's that the timing of the fever is neither sensitive nor specific for the presence of bacteremia. This was replicated in a paediatric population, which again showed a very small effect size that was only statistically significant in the oncology patients, but overall it didn't make a difference. So the question is there some sign which is a good predictor of bacteremia? And the answer is yes. There was one study which showed that if you take the blood cultures within about 2 hours of the patient developing rigors, that's fevery, shaky chills like that, then you've got a very good chance of catching the bacteremia. But by far the best predictor of whether you're going to grow anything in your blood cultures is the volume of blood that you collect. Even taking more than 5 millilitres would make a massive difference, and we know that this is a dose-dependent effect. You get an increased chance of finding a bacteremia for every 10 millilitres that you take. So that's what you want to do. You want to take lots of blood. The other thing is, take lots of cultures for the same reason, and we know that the chance of you growing anything increases for the number of blood cultures you take, and we generally don't take enough blood cultures. We usually only take one if a patient spikes fever. We shouldn't. We should be taking at least 2 from different sites, and we know that in endocarditis it's the standard practice to take blood cultures from at least 3 sites. Well, we should be doing it for at least 2 for every patient, but what we shouldn't be doing is taking blood cultures for any patient any time they spike a temperature, because there are so many causes of spiking temperatures. The patient might just be very hot, that there's no point. Okay? You should only be taking a blood culture for 2 reasons. Number 1, you strongly suspect sepsis or bacteremia, pyrexia of unknown origin, and you really think that there is bacteria present in the blood. The other reason is in a patient before you've given any antimicrobials, if they've got a deranged white cell count, that might indicate they've got an infection. Okay? In other words, you need to have some reason to think that they've got an infection before you take blood cultures. And if you take it after they've started antibiotics, we know that that decreases the chance of you picking up a bacteremia massively, to the point where there's really no point taking blood cultures more than 72 hours after you've started antibiotics. There are probably 2 main reasons why there's no point taking a blood culture in any patient who has a spiking temperature. First of all, there are loads of things that cause fevers. Malignancy, autoimmune conditions, anything really that causes a systemic inflammatory response. The other thing is that even if you've got someone who's profoundly septic, if they're an elderly patient, they often don't mount a proper immune response and are hypothermic instead of hyperthermic. So looking for a fever wouldn't make a difference. But overall, as I said, it's probably because by the time you've spiked a fever, your immune system has already cleared out the bacteria from the blood. So that's my quick review of the evidence. To summarise, you should take blood cultures for 2 reasons. Number 1, when you think the patient's got a systemic inflammatory response, and number 2, if the patient has a fever, you've not given antibiotics yet, and you've got some deranged white cell counts. Don't bother timing the collection of blood cultures with the fever. If you can, time it with the rigors, but just take it any time. Okay? Get those blood cultures taken. Take lots and take them often.